Hello, my name is Heather Donahue. Welcome to the Registry Partners May 2024 Oncology Coding Break. I am very excited to present on the topic of EOD and SEER Summary Stage when pericolorectal tissue invasion is present. This topic can be very confusing, so I think you will be pleased with the clarity and the guidance we provide you with today. I'm beyond excited to have a special guest co-presenter with me today. Her name is Melissa Meador. Melissa is a former oncology intern and comes with a plethora of knowledge as a former A&P professor for many, many years. So we'll focus on the conundrums of coding EOD of the primary tumor and SEER summary stage when the pericolorectal tissue invasion is present. This requires anatomy knowledge, some good investigational skills, and your thinking cap. In order to get this coding correct and provide accurate data, we really need to tap into all skills, practice diligence, and be sure to use the manuals and all available resources. So with that, what is the significance of the peritoneum and why is it so important for us to understand as registrars? Well, EOD and SEER Summary Stage both look at whether the segments of the colon and the rectum are either fully, partially, or not at all peritonealized when tumors do invade those pericolorectal tissues. The primary site's relationship to the peritoneum will determine the EOD and SEER Summary Stage. So we really do have to have a good understanding of the anatomy of the colon and the surrounding structures, know the meaning of peritonealized, know the synonyms of the word peritoneum, and know where to find that information and how to apply it. With that, I'm going to pass the mic over to Melissa to educate us on the anatomy of the colon and the relationship to the peritoneum.
Thank you, Heather. So yes, since I was an anatomy teacher, I'm going to be going over some of the anatomy here. So this is a slide of a wall taken from the colon, and it's showing the 4 layers of the wall that hopefully we're all familiar with. So we've got the mucosa, the submucosa, the muscularis propria, and then the serosa. So those would have been the 4 layers of the wall that you would have learned in your anatomy class. Now the mucosa, that's the epithelial layer. The food would be up here. This is where you're going to be doing your absorption. The mucosa ends with the muscularis mucosa, which is a very thin layer of muscle, and you will sometimes see that in the path report where they'll be talking about that thin layer of muscle. So all of this is the mucosa. Underneath that is the submucosa. That's where the blood vessels and the lymphatics are going to be found, and also the glands. So sometimes you see them talking about glands also. That's going to be in the submucosa. This is the muscularis propria. There's 2 layers of muscle. That's why they're showing it like this. There's a circular and the longitudinal layer. This is what's going to give you the peristalsis and is going to be moving the chyme towards the anus. And then we're also going to have the serosa. Now the serosa is a membrane. This is the outer membrane. It's made up of connective tissue topped by a layer of simple squamous. It's the outermost layer of the colon. And so those are the 4 layers that you probably learned in anatomy. As oncology data specialists, you hear a lot about the subserosa. Now, the subserosa is a connective tissue layer that is found between the serosa and the muscularis propria. Before, when we saw sub, and see the way this picture is oriented, here the submucosa is underneath the mucosa. Notice to make this the subserosa underneath the serosa, we're changing our perspective. So we're not going straight down, and so it's underneath in the respect that it's going to, if this was the outer layer and where our eyeballs are out here and now we're looking in, that's how it's going to be underneath the serosa. So this is going to be a layer of connective tissue that is between the muscularis propria and the serosa. And whether or not a tumor invades this subserosa is going to be different tumors that reach the subserosa are coded differently in SEER EOD depending on whether or not there is a serosa. So if the tumor reaches this part is going to be different whether there is a serosa out here or not. Now, the serosa can also be called the visceral peritoneum and is part of the membrane lining or covering the abdominal cavity. Okay, so here we have a sagittal section through the abdominal cavity. And so we're going to have the parietal peritoneum. So the parietal peritoneum is what lines the body wall. And it's going to be all here. And so this is all the peritoneum. And then we're also going to have the visceral peritoneum. Now, actually, those are the same membrane. So you have the parietal peritoneum is going to turn around and now become the visceral peritoneum. If it's touching an organ, it's called the visceral peritoneum. If it's touching the body wall, it's the parietal. So here we've got visceral peritoneum. This is going to be the lesser omentum here between the liver and the stomach. And then we're going to have the greater omentum that hangs off the stomach. This is going to be the transverse colon here. See, the membrane comes up. These are the mesenteries. This is small intestines, and the parietal peritoneum is still going to be coming around here. So if there is a peritoneum, there's going to be a serosa over the organ, and so that the liver, the small intestines, and the transverse colon are completely covered with the visceral peritoneum. So it's going to have a serosa. Then we've got organs that are retroperitoneal. The pancreas, the duodenum, and other organs are retroperitoneal. And there's a lot of lymph nodes back in here, and you will see retroperitoneal lymph nodes, and those mean that they are behind the peritoneum. This is going to be a transverse section, and just as a point of reference, these pictures are taken from the original Gray's Anatomy. There was a book called Gray's Anatomy, and that's where these pictures are taken from. This is a cross section through the abdominal cavity. So here's the parietal peritoneum up here. And so as it touches the organs, now we're visceral peritoneum, parietal. This is going to be mesentery. This is going around the small intestines. This is going to be visceral peritoneum, and then it goes back to being parietal peritoneum. Again, this membrane is all one membrane. We just changed the name based on where it is. So in this cross section, what we've got here is the ascending colon, and here's the descending colon. And as you can tell here, the peritoneum helps to hold the colon to the body wall. And so there's only a visceral peritoneum on the anterior and lateral surface. The posterior surface of both the descending and ascending colon are lacking a serosa. So if we're talking about the peritonealized surfaces, that's going to be the anterior and lateral surface of the ascending colon, the hepatic flexure, the splenic flexure, the descending colon, and the upper third of the rectum are all going to be peritonealized. What's going to be completely peritonealized, the transverse section is going to be completely peritonealized. The cecum is, and then as we get down to the sigmoid and the rectoid sigmoid colon, then what is not peritonealized is going to be this posterior surface. They do not have a serosal surface, and so if there's a tumor that is going to get into this pericolorectal tissue, then that is going to be localized spread, so the EOD is going to be different for these.
Excellent. Wonderful, wonderful anatomy lesson, Melissa. Your expertise has definitely helped me to better understand the relationship between the peritoneum, colon, and the rectum. So as we just heard, there are completely peritonealized, partially peritonealized, and non-peritonealized portions of the colon and the rectum. This slide is a reference table for coding EOD of the primary tumor and SEER summary stage when tumors invade the pericolorectal tissues. So disclaimer here, coding is provided, regional lymph nodes and other structures are not involved. You definitely want to consult the SEER Summary Manual and SEER RSA if lymph nodes and other structures are in fact involved. So moving down, completely free of peritoneum are the posterior surfaces of the ascending and descending colon, hepatic and splenic flexure, upper 2/3 of the rectum, and then all surfaces of the lower third of the rectum are completely non-peritonealized. When there is pericolorectal tissue invasion, all of these specific structures of the colon subsites and the specific segments of the rectum are coded as EOD 300 and SEER Summary Stage 1 localized. Structures that are completely covered by peritoneum, aka the serosa, are the cecum, sigmoid colon, transverse colon, and rectosigmoid colon. Structures that are partially peritonealized, as Melissa told us, are the anterior and lateral surfaces of the ascending and descending colon, hepatic and splenic flexures, upper third of the rectum, as well as the anterior surface of the middle third of the rectum. Any of these subsites and specific surfaces of the colon and rectum are coded to EOD 400 and SEER Summary Stage 2, regional by direct extension, when tumors of these areas invade the pericolorectal tissues. So when we're abstracting these cases with pericolorectal tissue invasion, we really do need to do some groundwork first. So first we'll need to tap into our investigational skills and determine the primary site, and then determine the tumor extension. Once we complete our investigation, we'll don our thinking caps and tap into our critical thinking and determine the EOD of the primary tumor and the SEER summary stage. So it sounds easy enough, right? Well, this isn't usually so cut and dry, and we'll see that in some up-and-coming scenarios, but this presentation will help you with working through these scenarios and coming up with the correct coding. Okay, let's take a look at case scenario number 1. So the patient presented with lower abdominal pain and then had a CT scan of the abdomen and pelvis that notes a left wall colon thickening and mild to moderate fat stranding, indeterminate lymph nodes in the area of the left colon. Patient has a colonoscopy. This states that there's a mass located distally in the descending colon, approaching the sigmoid colon. Patient is scheduled for a partial colectomy with operative report stating the mass is located in the sigmoid colon. Now let's take a look at the pathology report. We have a grade 2 adenocarcinoma in the sigmoid colon that invades the pericolorectal tissues, no LVI or PNI, no lymph nodes or tumor deposits, and it's a PT3, PN0. Okay, so now it's time to put those investigational skills to use. So first we'll need to determine the primary site, which would be determined using the SEER Appendix C priority order. And then we'll determine the extent of tumor. So we have the primary site as the sigmoid colon, which is based on the op report, which does take priority per that SEER Appendix C priority order. Next, we have the tumor extension, which is invading the pericolorectal tissues, and that's per the pathology report, and that is using the EOD general rules, which does state pathologic findings take priority over clinical findings. Okay, now that we've determined the primary site and tumor extension, we can work on determining the EOD and SEER summary stage, which is tapping into our critical thinking skills. Since we've determined the primary site to be the sigmoid colon, the next step is using the EOD notes and other resources to determine the sigmoid colon's peritoneal status. So I did use that handy chart that we saw earlier to determine that the sigmoid colon is completely peritonealized. So with that being said, how would we code the EOD and SEER summary stage? So that would be coded as EOD of the primary tumor 400 and SEER summary stage would be regional by direct extension. Okay, on to our next scenario, number 2 here. Patient notes a recent change in bowel habits and presents for colonoscopy, which reveals an ascending colon mass with biopsy proving mod-diff adenocarcinoma. CT notes colon wall thickening in the area of the known ascending colon cancer. There is no LAD or METS noted. Patient scheduled for a partial colectomy, has that partial colectomy. Op report note states that there's a mass located in the ascending colon. Then we have our path report. There's a 3.6 centimeter mod diff adenocarcinoma in the ascending colon. This is invading through the muscularis propria and into the surrounding pericolorectal tissues with small vessel invasion and no no lymph nodes or tumor deposits. Okay, so we're going to start our investigation again with determining the primary site and the tumor extension. So the primary site is the ascending colon, again per operative report, and the tumor extension is pericolorectal tissues invaded, and that is per the path report. Okay, so we have to determine the ascending colon's peritoneal status since we know the pericolorectal tissues were invaded. So as Melissa discussed earlier, the ascending colon has peritonealized and non-peritonealized surfaces. The posterior surface has no peritoneum at all or is retroperitoneal, and the anterior and lateral surfaces are covered by peritoneum. So what will we do next? Well, we do have an EOD of the primary tumor and rectum note 6 that does state, check for mention of serosa peritoneum in the operative report and or pathology report, final diagnosis, or gross description to determine the correct code. This also agrees with the SEER Summary Note 7 instructions. Okay, so we have to do some more investigation. So we saw the synoptic report, which does not mention anything about whether the part of the ascending colon is peritonealized or not, and the operative report also just stated the primary site, but nothing more. So next we will head over to the gross description of the path report, which does state that there is a palpably firm mass. It also states that the serosa is somewhat dusky. And then speaking of the mass, it says it appears to involve the entire thickness of the bowel wall and extend into the adjacent soft tissue. The serosal surface of the tumor is obscured by adherent soft tissue. Grossly, it is not clear if the tumor involves the serosal surface. Now with this information, we'll put our thinking caps back on. So the gross does state the serosal surface of the tumor is obscured by adherent soft tissue. Serosa is a synonym for peritoneum. So what do we have? Bingo! The tumor is in a peritonealized portion of the ascending colon. So therefore, the EOD is coded 400 and the SEER Summary Stage is coded 2 regional by direct extension. Okay, let's take a look at one last scenario. So there's a colonoscopy which reveals a descending colon mass with biopsy proving mod diff adenocarcinoma. The CT notes a known ascending colon cancer, no LED or METs. There's a partial colectomy scheduled and carried out. The op report states mass is located in the descending colon. Path report states that there's a 3.6 centimeter mod diff adenocarcinoma in the descending colon, invading through the muscularis propria and into the surrounding pericolorectal tissue with small vessel invasion, no lymph nodes or tumor deposits. So you know the drill by now. We'll start with our investigation to determine the primary site, which was determined to be the descending colon per the operative report. And then we need to determine our extension, which is pericolorectal tissue invasion, and that is per the path report. So now that we have our primary site, which is the descending colon, and our tumor extension, which is pericolorectal tissue invasion, we do need to determine whether the colon is partially peritonealized, completely, or non-peritonealized. So we can see here that the descending colon is also one of those sites that the anterior and lateral surfaces are peritonealized, and the posterior surface is retroperitonealized or non-peritonealized. So again, what do we do next? Well, we tap into that note 6 and we will head over to check out the operative report, which did just state the primary site, nothing about the peritoneum, and the pathology report final diagnosis, which also did not give us any information on the peritoneum status. So we will go to the gross description next. So continuing on our investigation using that gross description, because again, The path report synoptic didn't give us any information, nor did the operative report, which, by the way, is usually the case. So we do need to head over to the gross description. So looking at this gross description of the path report, it does state that there is a mass that appears to involve the entire thickness of the bowel wall posteriorly on the free wall of the bowel, and the tumor does not appear to extend to the lateral serosal surfaces. So we checked the gross description on the pathology report to determine the peritoneal status of the descending colon. And what we found was that the tumor was on the free wall of the bowel and did not appear to involve the lateral serosal surfaces. Don't forget, serosa is a synonym for peritoneum. So the tumor is not in the peritonealized portion of the descending colon. Therefore, our EOD would be 300 and our SEER summary stage would be 1 localized. And the last thing I want to point out here is when all else fails. Note 6 of the EOD and Note 7 of SEER Summary 2018 states, if the pathologist does not further describe the pericolic or perirectal tissues as either non-peritonealized pericolic or perirectal tissues versus peritonealized pericolic or perirectal tissues, and the operative report and or the gross description does not describe the tumor relation to the serosa or peritoneal surface, and it cannot be determined whether the tumor arises in a peritonealized portion of the colon, then code to EOD 300 and SEER Summary 1 localized. It's important that this is only used when a thorough investigation of the operative report and the synoptic final diagnosis of the path report and the gross description of the path report come up short. That is the only time you want to default to 300 and localized. And finally, these are the resources that we did use to put this presentation together. So please do check out those resources as well. Thank you for joining us for this month's Oncology Coding Break. We do hope that this provided some clarity on this rather complex topic that does tend to give us some trouble when abstracting. So don't forget to add this to your arsenal of tools for future colorectal case abstraction, and we will see you back here in June.